So this patient presented with inferior wall ST elevation MI, and he's a drug defaulter, like he was taking drug intermittently, antiplatelets, and now presented with the inferior wall ST elevation MI. He was a status post angioplasty, 1 days in mid RCA, and this is the left system. You can see the ectatic LAD, and this is the right radial root, and we have done the angiogram, and his troponin was around 40,000 with ST elevation in the ECG. So it was around 4 to 6 hours of typical chest pain he had, and as expected, you can see the large ectatic RCA, and thrombus is sitting right from the proximal RCA, and there is a total thrombotic occlusions right from the starting of the stent in the mid to distal RCA. And you can see how bad the RCA is, and patients still have a severe chest pain. And so with all clearance, with right radial root itself, we started the PTCA. With this JR guide, we engaged the RCA. You can see there is a problem in engaging the ectatic RCA while passing the contrast, while giving the contrast, there'll be a problem. So you need to be very careful while doing such a procedure in ectatic RCA. This is probably 4th, 5th case of my ectatic RCA angioplasty, and nothing has happened, any complications, but let's see in this case. Because in such a patient, there'll be a heavy thrombus load because of the large giant RCA. This is probably 4 millimeter RCA. So my plan is to put the wire. This is simple workhorse wire with BMW wire, and as expected, after crossing the wire, it took me 5 to 10 minutes to cross the wire. The thrombus was heavily thrombus was there, and organized thrombus was there, and you can see it took me almost around 5 to 10 minutes to cross the wire. And now this is the picture. What to do next in such a situation? Ectatic RCA with thrombus load right from the proximal to up to the earlier stent. So the next option is a probable aspiration, thrombosuction, or before that you can try with the balloon daughtering. So this is a balloon daughtering I tried with the simple 2 into 10 balloon, and I daughtered balloon. Balloon daughtering is an uninflated balloon. You can do the 2 and 4th motion of the balloon so that path may get clear. So after 2-3 heads of balloon daughtering, there's nothing. The flow has not come. So now what to do next? I decided to do thrombosuction. So thrombosuction has been done. I'll post the thrombus picture. We got a significant clot in the thrombosuction net, and this is the picture after thrombosuction. So in the at this point of time, I decided to put a stent in stent. So earlier stent was 28, so I decided to put a 30 stent, and let's see later what will happen to the proximal thrombus and all. So I decided to put a stent there, stent in stent. So while removing the thrombosuction catheter, it got disengaged, and again I had to put the wire. So this was a stent of 32 in length and 4 in diameter. Just I wanted to put earlier stent inside the length of the stent, and this stent has to be out so that there won't be any edge dissection or something like. So this is the 32 into 4 stent, and I deployed the stent at around 14 atmospheric pressure. RBP was 16, nominal was 8, and this is the picture. Now this is the after NC. I did the NC also with NC balloon. So we were happy, right? Okay, at the proximal you can see the some sort of vasospasm, and everything was good, but there is a long way to go thrombus was sitting right from the proximal RCA to the mid RCA, and even though RCA has got opened up in the distal RCA, you can see the distal RCA with the PLV, but there is a long way to go. Always there are complications can happen during the ectatic RCA angioplasty, that too in such a case. So my plan was after giving this tirafiban and everything, let's see the, so after giving this tirafiban intracoronary Nicoran, you can see the thing. Now we can see the CNA is getting worse and thrombus is getting appeared, and you can see the large thrombus in the RCA, the proximal RCA. So now what to do? There's only one way, just to do thrombosuction. So this was the thrombosuction catheter, and we did the thrombosuction in hope of we'll get the clearance so that we'll call off the day, but there was a very long way to go. And even after thrombosuction, you can see the CNA, and it got worse, then gets better. So this was the picture. So after even thrombosuction, after even balloon daughtering and all whatnot, after giving some tirafiban, Nicoran, NTG, this is the thing. So I decided to straight away put a stent, second stent right from the ostium of the RCA to mid RCA. But there's a cranial picture and you can have a clear-cut idea right from the ostium. So I wanted to put a length 40 length stent, but it was not possible to put such a long stent. It was not going. So I took a 28 stent so that I can cover that haziness part. And now just notice the contrast is not getting cleared in the aortic cusp, and you can see the how contrast is getting removed. So we deployed the stent, and it came to my notice that contrast is not getting cleared from the aortic root. I just deployed the stent, and now this is the picture. So now what to do? So again I decided, and at this point of time patient's BP went down. It went up to right from 140 to 90 now. Patient is was in chest discomfort, shortness of breath, and everything was there. So I did the echo at this point, and I saw whether there is any cardiac tamponade or any fluid in pericardium. So there was nothing. Echo was very normal. So anyhow, I wanted to put a stent right from the ostium. Now in this point, you can see the contrast is not getting cleared right from the aortic cusp, and the thrombus was sitting in the proximal RCA. So I wanted to put a stent right from the ostium. With the great difficulty, I propagated the stent in the proximal RCA. So you can see the positioning of the stent. I wanted to put the stent right from the ostium of the RCA, and catheter was not giving me support because of this dissection in the aortic root. So anyhow, with the positioning of this you see the position of the catheter was not ready to engage in the proper positioning, and anyhow patients was not stable. So I deployed the stent right from the ostium. Probably I missed some ostium. So I deployed the stent, and after deploying stent, there was a TME3 flow and everything went well. PP came up and patient's chest pain has gone up. Sorry, patient chest pain gone down. So everything was good at this point of time, and came to my notice that there is some dissection in the aortic root, right side aortic root, but it was not progressing. So I was like let's see what will happen. So I called up some seniors and asked what to do now. There is some dissection in the aortic root. Aortic dissection is there, but now patient's BP has got up. Echo is normal. Everything is normal now. BP is came up to 140. So now what to do? Then I search up the literature. This is the first case in which I got this catheter induced aortic dissection. So if it is concealed dissection, limited dissection, if it is not progressing to the ascending aorta, there's nothing to do. The conservative management. So I put this patient, I did the echo again, and there was nothing, no pericardial effusion, nothing. So you can see I missed the stent right from the ostium, but this is how this case has gone. So this is a case of aortic root dissection, probably type 1 aortic root dissection, which is confined to the aortic root. So maximum time the management is conservative. If it is going up to in ascending aorta more than 40, that is less than 40 is a type 2 and more than 40 is a type 3 aortic dissection, catheter induced aortic dissection. So this is there is a challenges in doing ectatic RCA angioplasty in such a cases. So this is a typical case, typical complications which has happened in this case, that is catheter induced aortic root dissection type 1. But anyhow, I kept this patient for 5 days and there was nothing. So I planned for the CT aortogram for this patient. Patient is stable and we discharged the patient on 3rd day, and now patient is good. As soon as after 7 days I will do the CT aortogram, and so this was the case of catheter induced aortic dissection in the ectatic RCA angioplasty.